hear her on the mic?
Yeah.
No?
No.
Yeah.
Yeah, hang on. Can you hear
Better.
me now? Yeah.
Better?
Better?
Better.
Okay.
Yeah.
I'm reaching everybody?
We're not that far away from you, don't worry.
Yeah, exactly. I'm a little soft-spoken. I'm always told I'm a low talker, so I need this mic as close as it can be. Well, hi, I'm Christine Nagy. I'm very, very honored to be here this evening. I do the morning show at Light FM, which is 106.7, and Bob Brunson is my co-host. But we'll be doing that tomorrow morning. Right now, we are closing in on October, which, as you know, is Breast Cancer Awareness Month, and something that's very close to my heart as well. So I know all of us have been touched by breast cancer, and we want the latest information and all the support we can get. And thank you so much to our panel for being here. So welcome to Breast Case Scenarios in the New Era of Personalized Medicine, presented by Summit Medical Group and the Anderson Cancer Center. With me today, our esteemed panel of leading breast cancer care experts from Summit Medical Group, MD Anderson. They'll discuss the latest advancements available for diagnosing and treating cancer and how an individual treatment plan is devised. And I feel like if I go this way, you can hear me better? Is it? Yeah? Just fine. Just fine, okay. So, next to me, Dr. William Deal is the Medical Director of Summit Medical Group Breast Cancer Center, specializes in the evaluation, diagnosis, and treatment of breast cancer and other diseases of the breast. Deal, thank you for being here. Dr. Winnie Paulin is a breast cancer surgeon, a breast surgeon, who specializes in diagnosing and managing benign and malignant breast conditions. She's also involved in breast cancer research and stays current on advances that can provide her patients with the best outcomes. Thank you. And Dr. Sue Jane Rivas-Grosso, Chief of Breast Imaging. She specializes in breast imaging, digital mammography, breast ultrasound, breast magnetic resonance imaging, and interventional breast procedures. Thank you. Dr. Geraldine Mercer is a pathologist with an expertise in cytopathology and gastrointestinal pathology. And next to Dr. Mercer is Dr. Jennifer Reeder. Dr. Reeder is a medical oncologist specializing in the diagnosis and treatment of a wide range of cancers with a focus on breast cancer. Dr. Molly Gable is the medical director of radiation oncology. Dr. Gable specializes in radiation oncology with a concentration in gynecologic, prostate, and breast cancers. And Dr. Elizabeth Nicole, who is with us on a very special evening because it is also her birthday. I just want to know, happy birthday to Dr. Nicole. Has clinical expertise in a variety of behavioral health conditions. She's provided psychotherapy and support to hundreds of cancer patients and is a 15-year breast cancer survivor. So thank you so much for being here. Thank you for your support. So let's begin the evening with Dr. Deal. Dr. Deal, you're going to tell us about a breast cancer case that we're going to be discussing this evening.
So this is the way that we, as a group, and many other parts of the country, arrive at decisions on how to treat patients. And we do it through what's called a tumor board. So at Summit Medical Group, we meet twice a month from 7:30 to 8:30 in the morning, and the specialties from all different walks of breast cancer are present at these conferences. And what happens is that the physician who would like to get the input of the entire panel will present the case to the whole panel. It is discussed, we show images, we show scans, mammograms, the pathology, and then a discussion ensues that allows us to come up with a unified treatment plan for the patient. So if you've ever wondered how we come to make some of these decisions for complex patients, this is the way that we do it. So what we thought we would do for the community is kind of give you an idea of what the process is like. I think you'll learn a lot about breast cancer, but also about the process by which we make these decisions. So the way the tumor board would start is I would present the case and then say this is a 60-year-old woman who is previously healthy, and she presented for her annual mammogram. She does not feel any masses in either breast. She is not on any medication, and there is a family history of a maternal aunt who had breast cancer in her late 60s. So on the mammogram, we found that there are two abnormalities, one in the right breast and one in the left breast. Both of these were completely unsuspected and unknown for the patient. So she is now being presented to the group for diagnosis and treatment recommendations. You want to show the mammogram, or we're going to wait?
Yes.
Okay. All right.
Okay, thank you, Dr. Deal, thank you. All right, so Dr. Cullen, we do have some questions, of course, regarding breast surgery. First off, does a patient with bilateral breast cancers need bilateral mastectomies?
Yes, so that's a very important question. So for surgery, there's two types of surgeries that patients can have to eliminate breast cancer. So one is a lumpectomy and one is a mastectomy. And so for us to decide which one's best for the patient, it depends on a multitude of things. So it's really not based on necessarily the type of tumor, the aggressiveness of the tumor. It's based on, for example, how many there are. So, for example, if someone had one area in their breast, it's easier to do lumpectomy, but unfortunately, if they have three separate areas, it's obviously harder to remove three areas. We can, but it leaves the cosmetic result not as much as what the patient would like afterwards. The other thing we consider is breast volume in relation to the size of the tumor. The reason is, for example, for me, as an example, if you have a smaller breast and you take out a tumor, let's just say it's 2 centimeters, it's going to leave, again, the tissue's missing, it's going to leave much more of a cosmetic change. Whereas if you do that to somebody with triple D breasts, it's not going to make much of a difference. So those are things we consider. In her in particular, with bilateral breast cancers, she does not have to have a bilateral mastectomy. These were actually, you'll see on the imaging, these were actually in relation to her breast size. You'll see they were small, and so it was possible that she got lumpectomies on both sides. So it is something that's possible.
So what determines if a patient needs a mastectomy or whether she can preserve the breast?
Right. So just like we talked about the volume, but it's also sometimes it's patient choice. There's a lot of patients, there's patient choice, and then there's of course medical data. So at this time, a lot of patients have to understand, and family members, that when you're given a choice between a lumpectomy and a mastectomy, sometimes your natural inclination is to go to the mastectomy. And the thought is, well, I have breast cancer, I should remove all of it. I don't want it to come back. I don't want it to bother me in the future. But what people don't realize is when you choose a lumpectomy, it's not just a lumpectomy. You're having a lumpectomy that goes hand in hand with radiation. And the thought is, if I remove the tumor, just in case, if there are any other smaller tumor cells that we can't see now, we of course don't want that to fester and bother you in the future. So the radiation helps us go over the remaining breast tissue. So that's how that is comparable. So it's a package. It's not just a lumpectomy. It's a lumpectomy and the radiation. As a package, and that is equivalent to a mastectomy. So that's very important for people to understand.
Can you please explain to us what a sentinel node biopsy is and why that's so very important?
Yes, so that is based on your tumor type. So you could have a lumpectomy and a sentinel lymph node biopsy. You could have a mastectomy and a sentinel lymph node biopsy. So the purpose of sentinel lymph biopsy is to see if, it doesn't mean it has, but if any tumor cells have escaped from the breast and gone towards the lymph nodes in the armpit. That's the first place it goes. So this sentinel lymph node biopsy is done in the axilla, the armpit area. And it used to be long ago, we didn't have good techniques to figure out where these lymph nodes are, which ones are affected. So a common question is, well, how many do I have in there? How do you find it? So on average, anyone has a axillary lymph nodes anywhere from 5 up to 30. And so think of it like a ladder. It used to be we couldn't tell, and so you would have to remove all the lymph nodes, and that unfortunately led to a lot of problems. Swelling of the arm, dysfunction, so better techniques were created. And then the sentinel lymph node biopsy, the thought is, think again, the lymph nodes are like a ladder. So what we test is we try to find the lymph nodes that are lowest on the rung, because the tumor cell's climbing up. So if you can check the first 1, 2, 3 lymph nodes, and there's no tumor cells in them, then it's likely not gone beyond that. So then we don't have to remove the rest of them. So that's the concept.
Dr. Collin, does a patient with bilateral cancers have a genetically transmitted cancer?
So that is something we definitely consider and look at. Again, that's a new hot topic, is genetics. We're all born with many different traits that we receive from our family members. And so for genetic testing, it became bigger in the news probably about 6 or 7 years ago when Angelina Jolie came out. And she unfortunately had ovarian cancer in the family and underwent genetic testing and then underwent some prophylactic surgeries. So we consider that in patients who have family histories not only of breast cancer, but ovarian cancer, melanoma, prostate cancer. There's many links between different types of cancers and different gene mutations. But in particular, for breast cancer, yes, if you have breast cancer, unfortunately, on both sides, even if you have no family history, that is one of the criteria that we will actually send you to be evaluated for genetic, to see if you have a genetic mutation.
Thank you very much. So I think we'll be moving on to the importance of screening. Dr. Rivas-Grosso, some questions for you. Can you explain, please, the difference between mammography and breast ultrasound, and why we can't just have a sonogram and not a mammography? And what is tomosynthesis? Yeah?
Tomosynthesis.
Tomosynthesis.
Sometimes you hear it as 3D. You may have heard there's 2D mammography and there's 3D mammography. So, thinking about this patient, for example, right? She had a mammogram, and as Dr. Deal said, she did not feel anything. This was a routine screening mammography. So we believe in screening starting at the age of 40 with mammography, and then every year after that, unless you have some sort of genetic risk. So the question about the difference between mammography and ultrasound, mammography right now is the only proven tool to have really affected the mortality rate of patients for the possibility of breast cancer. So mammography remains the most important test that you can have to detect breast cancer early. Mammography is actually an X-ray. So you are getting an X-ray of both breasts. Ultrasound, on the other hand, is not radiation. It is using echoes, basically, to create an image. However, ultrasound does not demonstrate some of the smallest cancers and earliest cancers that we like to find, such as what we call ductal carcinoma in situ. Ductal carcinoma in situ oftentimes shows up as calcifications, and we can't see calcifications with ultrasound. So that would be a very big difference between the two. Ultrasound is used as a supplementary exam. So if I look on a mammogram and we see something, we're not sure if it's a cyst, for example, then we would use ultrasound, which would help us identify a cyst. So there are definitely clear differences between the two, and your doctor would be able to help you to determine whether you should have an ultrasound or not. But mammography is the first one. And tomosynthesis is the latest technique that we've been using, which is the ability to get what we call 3D images. So the machine, some of you may have had this test, but you see that now the machine moves. So if you know anything about CAT scans and how we take images, basically slices through the body. So now with mammography, the tube actually moves in an arc, and it actually takes images as slices that go through the breast. And we can take that data and create 3D images of the breast itself. And it's really best for women that have very dense breasts.
Can you please explain what exactly is the MRI and how that's different from mammography and ultrasound?
So I think, as a radiologist, the best thing for me is to actually show the images. Because the,
Okay. Yeah.
okay. So if you see up here, this is a 2D digital mammography image. And this particular patient that came in that could not feel anything, you can see, I don't have a pointer, but there on the left side, right here, you can see that there's a white spot. That white spot is the area that was of concern. And with tomosynthesis, it had slices that went through it. And I'm sorry I don't have that because I would need a video to be able to show that because we have so many images. But that one is not so difficult to see. On the right side, you probably cannot see what we're looking for. It was not easy. So the tomosynthesis actually helped us. And this woman actually does not have dense breasts. She's actually on the fatty side. So on the left side, you can see there's a white spot, probably, right? You see that up there on the left side?
When she's, I'm sorry to interrupt you. When
Yes.
she's talking about the left side, it's as if the patient were standing looking at you. So when she's
Yeah.
talking about the left side, it's actually on the right side of the screen.
Mhm.
Oh,
There's a pointer. Oh my goodness. Nice. Okay. So here on the left side is an abnormality. It looks like a mass and there's irregular borders to it. And that's what a radiologist does. They kind of look at the shape, they look at how it looks and whether it looks suspicious or not. On this side, very difficult to see anything. And here, this is one side. This one you can clearly see is abnormal and the patient cannot feel this. On this side, very difficult to see, but maybe there's something here. So we do additional imaging with mammography, and when you do a spot compression view, here it is, you can see a little better. And on this side, you kind of see a tiny little white spot, very small. So the difference between mammography and ultrasound, well, here's the one on that side that was abnormal, and you come here, I'm sorry that says right, but it's actually left. And here with ultrasound, these are echoes, and this mass blocks any sound going through here, and it shadows, and that tells us that there's something abnormal there. And what's good about doing the ultrasound is that when you find it, they can go to someone like Dr. Deal or Dr. Poland or a radiologist like myself, and here is the mass, and it can be biopsied. And with ultrasound, you can also look at the lymph nodes. So when we talk about sentinel lymph node biopsy, you know, these are some of the lymph nodes that you're looking for with ultrasound. And this is a procedure that actually was done by Dr. Deal, where he has this needle and he goes right through with ultrasound and you can actually biopsy it. So your question about MRI, here's an MRI, and you can see that looks very different. An MRI actually is a magnet. So again, it's not radiation, but it's a big magnetic field. And using that magnetic field and using contrast, we use gadolinium that is injected into the veins, we learn about the flow. So now MRI is really about what is enhancing or what has a lot of flow. Cancer has a lot of flow. And you can see all of the vessels here. And what the radiologist is looking for is, do we have just one spot or are there other spots in this breast that maybe we didn't see with the other images? And here we can see this black spot, which is actually a clip that was placed by Dr. Deal. And I can tell that this is the area of the abnormality, and so I'm looking for other areas. But what about the other side? Well, here's the other side, and that little white spot is the abnormality, and there's the little clip that you can see. I hope that answers the question.
Thank you. So how do you determine which patients get the MRI, and how does MRI change treatment plans for the patients diagnosed with breast cancer?
So I think that's where the team becomes extremely important, because every patient is different, and you have to sort of determine what is the best imaging for each patient. A lot of it has to do with physical exam, it has to do with their mammogram, are they very dense, are they not? Are we, are there genetic predispositions that will determine whether the patient requires an MRI? Patients that get MRI are usually either high risk with genetic, risk for the possibility of breast cancer. But if a woman is diagnosed with breast cancer, often those women will get an MRI to be able to see things better. And that's usually determined by their surgeon. The surgeon will talk with the patient, see their images, look at the pathology, and determine whether they need an MRI in order to assess that patient further.
Okay, so we're going to move on to pathology of breast cancer. Dr. Mercer, you can guide us and help us understand the challenging terms that we might hear with a breast cancer diagnosis. So what does it mean if breast cancer is called ductal, or is it lobular, or carcinoma with ductal and lobular features? And is this related to the cadherin test? Yeah, thank you.
So most breast cancers can be divided into lobular or ductal carcinoma. And it's the way they look under the microscope for us that we can determine it. Sometimes there's an overlap and there's a mixed population of both types of cells. go to do an e-cadherin stain. The easiest way to think about the breast cancer itself, the tumor cells, is that they arise in the milk ducts originally, and it's the cells that line the milk ducts. The simplistic way of looking at it would be is if you looked at a neighborhood composed of a lot of little streets ending in cul-de-sacs, and it's in those cul-de-sacs is where the tumor arises. And the tumor cells themselves would be what you would almost think of as the curb. Okay, and those are the breast cells that you have normally in your breast that produce the milk. So when they go awry and they develop cancer, that is where they start.
So, the difference between infiltrating, invasive, and is it in situ?
In situ.
In situ carcinoma, please.
Yeah, so invasive and infiltrating is the same thing. And it's basically, again, if you think about the neighborhood, and you think about the cul-de-sac and the streets with the curb, the tumors arise there, that would be the in situ cancer. It means that the tumor cells are still confined to the milk ducts. Once the tumor cells invade or infiltrate beyond the ducts into the surrounding connective tissue, then we use the term invasive or infiltrating. So you almost think about it again in the neighborhood, those would be the tumor cells that would climb up onto the lawns of the houses. They're no longer within the street or lining the curves of the street.
And please, the histologic gauge or grade as well as the Nagy grade. If you can explain that to us.
Yeah, so if you read a report, you would see that the tumor is always graded. It's the way that it looks under the microscope. So you'll see histologic grade. Histologic just means the way it appears under the microscope. There's different types of grading systems. The most common here in the United States is the Nottingham grading system. And we look at three things of the tumor. One, the first thing is how closely the tumor looks to the normal benign breast tissue. And that would be given a lower score, or we call it well differentiated. The second thing we look at are the individual cells themselves and how the nuclei or the cell itself looks. Bigger cells, darker cells, or just say ugly cells, that becomes more poorly differentiated, gets a higher number. The last thing we look at are mitotic figures, or how the cells are dividing. And if we see a lot of those mitotic figures, again, it's given a higher score. So higher scores equal poorly differentiated, lower scores equal well differentiated, meaning poorly differentiated tumors are more aggressive and need more treatment. And that's what we would discuss at the conference.
Thank you. All right, so Dr. Reeder, coming up. Microphone's coming at you from every direction.
Yes. Extra loud.
Oh, you're lucky. You have it too. Okay, so we're moving on to therapies and treatment, please. What is the Oncotype test?
Oncotype?
Test. How's it used to help determine the need for systemic therapy?
So when I first meet with patients, I usually kind of put things into context as far as what my role is going to be in their journey. And so what I usually say is really anytime a woman is diagnosed with breast cancer, there's sort of three areas of treatment that we consider. Not everybody needs all three of those, but we at least give it some thought for each of those. So one area is surgery, which is usually fairly self-explanatory, and that's going to be Dr. Pullman or Dr. Hill's area. The second part is radiation therapy, which Dr. Pullman talked about. And then the third part is what I call whole body or systemic therapy. So that's the part that a medical oncologist does. That's what I do. So my part comes also in two parts. One is chemotherapy, people who need that. And the second part is anti-estrogen therapy for people who need that. So we have different criteria that help us determine who's going to need each of those things. And it's not an either or for chemotherapy and anti-estrogen. They're individual decisions. So getting back to what systemic therapy means, again, it means sort of whole body treatment. So the surgery and the radiation are localized treatment to the affected area of the breast or the lymph nodes. But they don't do anything to treat the rest of the body. And once a woman has surgery, if we could say on that day, there's no cancer cells left in the body, we would be done. We wouldn't have to do any further treatment. But we know from decades of research that there are women that will have the cancer come back at a later time. And we know that that must be true, possible, because So, back to the Oncotype test. So the Oncotype test was developed about 15 years ago. Prior to that, we would see a woman with, any woman with a 1 centimeter or larger breast cancer, and we would treat her with chemotherapy. We knew, estrogen receptor positive, I should say. We knew at that time that we were over-treating women. We knew that out of 100 women, probably only about 25 actually needed the chemotherapy. But the problem was we couldn't tell who was who. So we said, well, we should treat everyone to make sure we benefit those 25 people. So along came some information about the actual DNA makeup of cancers. And the Oncotype test was really sort of the first test that was developed when you hear about or think about personalized cancer care, where you can take a person's individual tumor and send it off for this DNA test. That's what the Oncotype is. It looks at a set of 21 genes, and they did some validating studies on hundreds of samples, and they said, okay, if you have a particular profile, for example, these 10 genes are high, and these 11 genes are low, that's a low risk profile, and that is someone who has a lower risk of recurrence, and they found that those are patients that actually do not get any benefit from chemotherapy. On the reverse, if those 10 genes are low and the 11 genes are high, that's a high risk profile, and those are people who clearly do benefit from chemotherapy. So the Oncotype was developed to allow us to help define out of those 100 women which 25 are likely to definitely benefit from chemotherapy, about 50 of them who clearly did not benefit from chemotherapy, and then there was, up until the last 6 months, still a significant gray range of about 25% of patients who would fall into an intermediate area. One of the new things that just came out, relatively hot off the presses, was you might have seen a news splash about how there were a lot of women that no longer need to have chemotherapy that we would have treated before, and that was that intermediate Oncotype. There was an update on the study that says that a lot of women who have an intermediate Oncotype do not benefit from chemotherapy. So we now are much more comfortable saying to those women that they don't require chemotherapy, which is a huge benefit to a lot of people. So that's what the Oncotype test is. I should also say it's specifically designed for patients who have an ER positive and HER2 negative cancer. Because I get that question a lot too, when people who don't fit in that criteria and say, what's my Oncotype? Well, it actually isn't used for people who have either a triple negative cancer or a HER2 positive cancer.
Okay. So the options you talked about, anti-estrogen therapy, right? What are the differences, and how do you determine which one is the most appropriate for a patient?
So I was talking about the chemotherapy. The other part of what I do is anti-estrogen therapy. So most of those women who don't benefit from chemotherapy, who are ER positive, are going to get significant benefit from anti-estrogen therapy. In general, anti-estrogen therapy reduces risk of recurrence by about 15%. So if someone has a risk of recurrence of 20%, they'll cut it down to 10. So it's usually a significant good benefit. There are two major categories of anti-estrogen therapy. One is tamoxifen, which is the one oftentimes people have heard of because it's been around a very long time. And the relatively newer medicines called the aromatase inhibitors. There are 3 individual drugs in that category. And then tamoxifen is sort of by itself is its own agent. Tamoxifen used to be the standard of care for everyone, premenopausal, postmenopausal, estrogen receptor positive. But the tamoxifen carries with it a small increased risk of uterine cancer, and it carries with it a small increased risk of blood clots. So although those risks are both very small, single-digit percentages, it made oncologists nervous and patients nervous. Particularly that risk of blood clots gets higher as you get older. So for a woman in her 70s or 80s, it gets a little more concerning. So they developed the newer drugs 20 years ago, the aromatase inhibitors, which don't have those risks and work in a different mechanism to block estrogen and blocks estrogen from feeding breast cancer cells. And so now they have become the standard of care for postmenopausal women for 2 reasons. One is that they're considered a little bit safer because they don't carry those risks that tamoxifen carry. And the second reason is that they've been compared head-to-head in quite a few large trials now, and they've always been a little bit more effective than the tamoxifen. And so they became the standard of care for postmenopausal women. Tamoxifen is still the standard for premenopausal women.
Dr. Gable. We'll move on to radiation techniques and individualized treatment plans. So please tell us what we need to know. For instance, does everybody need radiation after a lumpectomy?
Many do, most do, because I don't want to disagree with Dr. Pullen. The way that, and I don't disagree with her, the way that I explain it to patients is based on data that we have. And so the first data that came out compared thousands of women in actually multiple countries who were treated with either mastectomy or lumpectomy and radiation. Some of these studies just did lumpectomy alone. And whether it was in Italy or Canada or America, interestingly enough, the chance of it coming back without radiation was 39%, not 40, not 38. Very strong data. So for the vast majority of patients, yes, you need radiation. However, over the past probably 15 years, I remember 20 years ago writing a paper with a surgeon because our older patients would say, and older are people that we consider young now, a 73-year-old would say to me, I don't have that much life expectancy. I hear what you're saying, Dr. Gable, I don't want radiation. Same thing to the surgeon. So people started doing a study asking the question, are quote-unquote good little small cancers, is it safe to just do lumpectomy? And we do have data. We always base our decisions on data. And so these studies included patients 70 years of age or older. They all had small tumors, just like this patient. They were low grade, getting into what Dr. Mercer was talking about. And then the tough part for all of us is that the surgical margin. And many of you may be familiar with what a margin is. The way I explain it to patients is using my wedding ring. So if this was all removed, my hand was removed by Dr. Deal, and the tumor was my wedding ring, as you can see, my pinky is a nice margin. Okay, there's normal tissue around my wedding ring. The definition in studies of a negative margin is 3 millimeters, so that's about the average width of a wedding ring. That sounds pretty small to you and me, but remember, tumor cells can't be felt and they can't be seen until Dr. Mercer looks at it. So in our world, 3 millimeters literally is like from here to the pharmacy. It's huge if you think of all those normal breast cells that are in between it. So 3 millimeter margin is a very wide margin. So in that select group of patients who did not get radiation, the local recurrence went from almost 40% to 10%. And so we know from that we can tell patients that if you choose not to have radiation, you only have a 10% chance of it coming back. The flip side, which is what you see in the lay literature, is 90% of women don't need radiation. Yes, if they meet all those criteria. Getting to this patient, this was not my patient, but my partner's patient. So he saw her, we all have that, radiation oncology, have that discussion with the patient, do they need, and we explain the data that I just explained to you. In her case, and I totally agree with his conclusion, he did not offer her or recommend no radiation because her surgical margin was close, which is no fault of Dr. Deal, as I just explained. It's, he got about to the last chair, which is darn good, and there's no way to predict that. She is 57 years old, but we no longer age people that way. In fact, we do have some smaller studies of 50-year-olds and older who can safely omit radiation. So take my word, probably in about 5 years, we won't be talking about only 70-year-olds or later. And then the softer spot, which we were talking about a little bit earlier, she has bilateral breast cancer, and that makes us nervous. We don't have all the answers, of course. And we know there's something going on in that tissue that places her at more risk. And so for that reason, he did, and I would suggest that she have radiation in her specific scenario.
I think you started to touch upon this then. So what has changed in the past 5 to 10 years from the radiation perspective?
Happy to say, less is more. So much like, and again, this is the way that I explain to my patients, in the 60s or 70s, someone had to have a radical mastectomy. And then in the 70s, it became modified radical mastectomy, which meant the woman could use her arm much better, etc. In 1980, I sat there at Harvard as the note taker while my mom was diagnosed with an aggressive breast cancer. And they presented us the data that I just explained, the 40% width, but that was pretty unique and forward thinking even in the 80s. And like the surgeons, we're a little bit slower on the uptake. Like the surgeons, now, 30 years later, we're starting to ask, is less more with radiation? So I just explained about how we can omit radiation, but in patients like her who need radiation, do they really need, I've been doing this for 28 years, and for 15 years of that, I told people you have to come every day for 6.5 weeks. I can't remember the last time that I had to ask that of a patient. Because we started asking, much like the story with mastectomy, is less more, in 2 ways. First, the schedule. This started in Canada and in Great Britain, and also to a lesser extent in Australia, where there's socialized medicine, and they didn't have enough linear accelerators to treat all the patients. So it was practical. So they said, well, do the math. If we could treat it faster, there'd be less number of treatments. Is that safe? So interestingly, Canada is really the lead on this because they published it first. But again, the same exact data, whether it was Canada, Great Britain, Italy, Australia, who's now publishes a lot on this, exactly the same outcome, giving a little bit more dose every day, and then the patient can come, depending on their margin status, for 3 to 4 weeks, totally safely. Same cosmetic outcomes, same survival. Then we took it one step further, again, borrowing from the surgeons. Could we possibly treat just part of the breast, the area that's at most risk? And you may think, and I will fully admit, I was totally wrong. I thought this was cuckoo. I thought you give radiation to part of the breast, it's gonna scar, it's not gonna be this great cosmetic outcome, and I'm delighted that I was completely wrong. The cosmetic outcome is the same, but what I see in patients that I treat, when you treat partial breast, there's much less radiation to the lung, to the heart. And I can look a patient in the eye and say, I'm not gonna deliver any radiation to your heart, which is helpful. Sorry, that was a long answer.
No, it's wonderful information, thank you. It leads into our next question, because there are reports of heart damage from radiation when patients are being treated for the left breast. So how do you decrease that risk?
So that comes from actually, in part, technology. So again, in the 70s and 80s, we used a radiation that was more penetrating. It's all that we had. And also, in the crisis of the moment with a woman who's diagnosed with aggressive breast cancer, you may not be thinking, because we didn't have CT scans and MRIs and all this wonderful technology, you're thinking, oh, the heart's like 4 or 5 centimeters away, that's that far. And then we started getting reports. And we also started getting our technology where we do CTs, and we went back and looked and said, even when we're treating at an angle, we're still treating the left ventricle. That's where everyone who has a open heart surgery or a heart attack, it starts in the left ventricle. So there are now 2 techniques that are new, probably over the last 5 to 10 years also. One is that we use what's called breath hold technique. And we have just a little black box that is sitting on the patient's stomach. They can't even feel the weight of it. And as they take a breath in, that's when we give the radiation. Look down now and take a deep breath. You will see your breast, whether you're male or female, move. It moves away from the heart, and probably by about this much. So that takes the dose to a heart from a risk of 5% to basically hypothetical. The other way is to have a patient lie prone or on their stomach, where their breast can fall, and thankfully, someone got funding in the radiation field, so it's a very form-fitting, cushy, comfortable table to lie on, and then the breast just falls. We treat the breast. The heart and the lungs are way up here at the table. They don't get any radiation. So those are the two ways. And different institutions have different, and it's also we give patients the choice whether they can hold their breath for 15 seconds, which can be intimidating, or for other women, I don't want to get on the table, I have to kind of crawl on my hands and knees for a second, and that's humiliating, so we let them choose.
So much to think about. Thank you very much. So on to our special birthday guest, the emotional and psychological toll of cancer and that diagnosis. We'll get into that. For anyone on the cancer journey cannot be ignored, and that's why Dr. Cole is here. Thank you for all you do as well. So what might be the psychological difficulties a patient with this diagnosis could experience?
So this patient, if you remember at the beginning when Dr. Deal talked a little bit about the patient, this patient was completely healthy, close to 60 years old, and was not necessarily expecting that they would go for their mammogram and find out any sort of bad news. This is like being hit by a freight train when you don't expect bad news and all of a sudden you hear the word cancer. So I oftentimes try to explain to patients that what they're going through is similar to the loss of a loved one. So if anyone has ever grieved the loss of somebody very close to them, it's incredibly painful. When you hear the person has died, you experience things like shock. It's incredibly sad, it's scary, and we don't quite know how we're going to go on. And of course, when someone's diagnosed with cancer, it's not only what goes on while all of these wonderful doctors are treating them, but also what goes on for them in the years following. Now, the hard thing for someone who is a therapist is that I don't have the wonderful tests and technology that these guys do. I only know that someone's hurting if they either tell me or they tell one of these doctors. And that's ultimately how they get to me. The interesting thing, and this has been new in studies in the last 2 to 3 years, American Cancer Society put out a study last year that 20% of all cancer survivors could be diagnosed with post-traumatic stress disorder. So think about that. Think about what we know about PTSD. A soldier goes off to war, experiences terrible, dreadful things, and then comes back to people who may not have been at war with them. And they live in sort of this quiet discomfort inside their mind, not really knowing who they can trust and who they can turn to. What's different for a cancer patient, right? They're told by probably one of these doctors that they have a disease that if they do nothing about, will kill them. To me, that's no different than standing on a train platform and being held up at gunpoint, right? So there's a threat of death, and then there's a threat of very difficult treatment. And again, I think unfortunately people still think of treatment the way we thought of it maybe 50, 60 years ago, and we pictured people disfigured, or we pictured people throwing up after chemotherapy, which is so much not the case today, but either way, if we've got experience, that might come to mind. So emotions like shock, disbelief, anger, fear, guilt, surprise, right? I've had patients say to me, I run marathons, I eat a vegan diet, how is it that this happened to me? Then on the other hand, I have the woman that says, oh, I smoked some cigarettes when I was in college. Did I do this to myself? So there might be feelings of guilt. It can be very confusing, but I think the main thing is that whatever the emotional experience is, it's normal. It can be completely across the spectrum. And I think it's important to note that it can happen at any time during a cancer survivor's journey, from the moment that they're told all the way to many, many years in the future.
So at what points during this journey that we're talking about do you find are the most emotionally distressed or at risk?
So the obvious one that I think we would all think about is the diagnosis, right? You are in your doctor's office and you're told that you have cancer. And in those days following, life is about to change. There are lots of decisions to make. So that's obviously a touch point at which somebody might want to talk to somebody. Then it can also be along the way. You heard there are a lot of decisions to make here, right? What kind of surgery am I going to have? What kind of medication am I going to take? What kind of chemotherapy do I need? What follow-up tests do I need? Do I need radiation? A lot of times, parts of this are within the patient's control, and they get to decide what's the right treatment for them when it's all been laid out
It's scary to make those decisions, especially when most of us have lots of loved ones in our lives that are telling us what we should do, right? And there's all kinds of conflicting information. So making decisions can be really tough. I think for me, the surprise, not only for myself having survived cancer, but in the patients that I work with, the most common time that I get them is after all of this is over. And there's a reason for that, because number one, they've lost their support system. They're not seeing their doctors as often. Additionally, people in their lives look at them and say, you're alive, you're done. This is a celebration, you should be happy, and yet the person is kind of thinking to themselves, oh my gosh, I'm completely alone. Nobody understands, I should be happy, why am I not happy? Why am I crying? Why do I feel so anxious? So luckily, at times, people will speak out to someone that says, oh, maybe you should go and you should talk to someone. Sometimes patients trust their doctors enough to say, everyone's telling me I should be so happy and I'm just not quite there. But really, I've had patients come in 5 years after they've finished treatment to say, you know what, this big thing happened to me and I really never worked through it, and I think I need to run this past somebody.
So what treatment would be recommended? Is that assistance available here at Summit Medical Group, MD, Anderson Cancer Center?
So the pride and joy of working here is that we're not only talking about removing and killing the tumor, but we're talking about a patient's overall well-being, which is so important, which is how do you live having gone through something that was so traumatic. So there are many touch points along the way at which someone from my team or myself might be brought in. So the first is we have integrated behavioral health therapists that actually work in the cancer center. So let's say that you break down in one of your doctor's offices and they feel that it might be helpful for you to talk to somebody. We can immediately have someone come right to the room. In the same way, the nurses are invaluable to us because as someone's getting chemotherapy, should they start to cry or say, wow, I'm having a really tough week, or my husband doesn't understand, or nobody could come with me today, we can send somebody chairside to talk to them during chemotherapy. Then, of course, there's the therapy angle, which is if patients say, I really need to talk to somebody. Lots of times, these guys will send me patients that have had breast cancer, because I've also had breast cancer, and I'm a therapist besides. And it can be really helpful for those patients to talk to someone who can at least say, I don't know what you specifically went through, but trust me, I get it. In addition, there are 35 therapists at Summit Medical Group in our Cognitive Therapy Center that not only work with patients with all kinds of medical conditions, but will also work with family members. So sometimes I might be seeing the cancer patient for therapy, but I might send their husband to see someone over at our behavioral health center. We have so many support groups, everything from general cancer to breast cancer, newly diagnosed, survivorship. We have advanced cancer for people who have metastatic disease, and we also have caregiver support groups. We also partner with the community on all sorts of different things that are going on out there that might be very specific to a patient. So we can be with them every moment of the journey, and there's so much for them out there.
That's wonderful. Thank you. Giving us such incredible, valuable information, and I know it's a lot that we're going to take home and think about and process. If you have any questions for our panel, this would be the time. Did you want to pass the mic around, or you just?
Well, does anyone feel that they need a mic? Yes. Okay. No, I don't know if I need a mic or
Thanks. Thank you for coming, everybody, and for all the information. I'm not sure to whom I should address this, but as far as biopsies, ultrasound guided biopsy, how can you be assured that that the biopsy was big enough, and should that? It seems like then the radiologists go by that report, and that's the one thing they look at then, just the biopsy report, and not so much further mammos or ultrasounds.
So
maybe there were a couple questions in there.
I'll start mine and then we'll talk about it. Sure. So as you can tell, we all work very closely together. So the biopsy is initially performed by the surgeon. And especially under ultrasound, the reason why it's done under ultrasound is, if you remember the picture with the white line going through, we can actually see the needle literally going through the target, the area. That's how I'm confident I know I got the tissue, the area that's abnormal. And then, of course, it's sent off to the pathologist, and obviously, if for some reason they see something other than what I'm expecting, it's called concordance. So I'm expecting cancer, but if it comes back and Dr. Mercer, the pathologist, looks at it and says, you know, it's just benign breast tissue, we do look at that and say, you know what, that doesn't make sense. And then the radiologist, also, they picked it up initially. They will also look at the pathology and decide it's called concordance. I'll have Dr. Gossett.
So just as a follow-up to that, can a benign biopsy, like dense stromal fibrosis, can that continue to show up with shadowing?
That's a very good question. Something that is stromal fibrosis can definitely have shadowing, but this is where it is important to find out or to determine whether there's concordance or not. So what happens is the radiologist looks at the images and describes it in such a way as to what their suspicion is about the possibility of cancer. Then, you know, the surgeon, a submedical group, will biopsy it. And oftentimes they come and they have discussions with the radiologist. You know, we have these little sessions in our offices where they come and they look at the images, and then we may decide, you know, either we believe it or we don't believe it. And if we don't believe it, that's why we have these other types of tests. They may say, for example, you know what, let's get an MRI. You know, maybe the MRI is going to give us more information. Or if we're not satisfied with that, we may talk about it, and the surgeon may say, you know what, let's take more tissue out. So it depends also on how many cores did they take. You know, when they biopsy it, the surgeon will know, I was in there, I saw it, I biopsied a lot of it, you know, I know exactly what I took, and they may say, you know what, I'm pretty comfortable with that diagnosis. So there's so much that goes into it, and I don't know if that answers your question, but yes, you can have something that has shadowing that is fibrosis. But again, you know, the surgeon and the radiologist should be involved in.
But you get to a point where you don't want to be so type A about it, but you want to be responsible too, and it gets complicated.
You know, I think what I always say to all of my patients, and I'm sure all of you do, you know, you are your own advocate.
Right.
And I think any patient, you know, if you have a question and it doesn't sit right with you, that's why you go and you speak to your doctor. And your doctor will work with you on explaining whether it is correct or it's not correct, or if you need something else. And that's why we haven't talked about navigators and how important the navigators are. You know, in our group, you know, usually the navigators are very much in touch with you. We have some of them here. And these are the kinds of things you bring up, you talk about, and we can always go back and look at those images. And we do recommend, if you want a second opinion somewhere else, some patients, sometimes they do that. Your films are yours to go and get those. But you can get second opinions right here, because you can have, I'm one radiologist, but I have 7 other breast imagers that I can show images to. And here we have several surgeons, and that's why we have tumor boards, because we bring it in and we say, hey, what do you think?
Yeah, and if we can't explain something as being benign with a 99% plus certainty that it's benign, we'll take it to the next level and the next level, up to the point that we'll take people to the operating room and just remove the thing. You know, we think something is cancerous and we just can't prove it. We'll take people to the operating room just so that we don't miss anybody. But it's a rare event anymore. We can almost always be sure that we've made the correct diagnosis without having to take somebody to the operating room.
And then just one last thing. So then the question is, if the biopsy was benign after an ultrasound guided biopsy, but there's still shadowing, how long do you need to have an ultrasound or mammo? Because it doesn't show up on the mammo. So, you know what I'm saying? Again, without being so crazy about it, but not being responsible.
So you're telling me that there's an abnormality that was not seen by the mammogram, was seen by the ultrasound, looked like shadowing, a biopsy was performed, it came back benign.
Correct.
Correct?
Correct.
And a lot of times after a biopsy, we do follow people, you know, in 6 months. We may follow it and see if it's changed or not. We do look to see if there's any change. You know, if there's any question that you have, you know, you talk to your doctor and say, you know, I'm not certain that I agree with this. I'm not feeling good about this. Is there something else I can do? I don't know if you've had an MRI, but that may be something. But I think that you should feel pretty comfortable and confident that if this person is just following you and they feel that it does make sense, then that's okay. Follow-ups, we do usually follow-ups every 6 months up to about 2 years is what the category that we place patients. So I hope that answers your question.
Yes, thanks. I don't want to monopolize, but maybe this will help someone else.
Any other questions?
So the tumor board thing really fascinates me, I guess. Having been diagnosed about a year ago, was this in place a year ago, or is it has been in place? Okay. Is it something where it's done once every couple of weeks? You said every 2 weeks. Is everyone required to go, or is it just to kind of have something I want to present? Because I have this image of like multiple, like hundreds of people sitting around in an hour every 2 weeks and not getting anything done.
Well, we have, no, it's actually a quite productive meeting. We spend about an hour twice a week. There are usually between twice a month, between both campuses, we probably have 25, 30 people present at the tumor board. And we'll go through 8 or 10 cases, sometimes 3 cases if they're very complicated at each session. And again, they are based on need for the physicians to have a question answered, need of the patient. Sometimes the patient will say, well, listen, I'd like some more information. So I said, well, we'll present it to the tumor board. The other thing that we also have available, like this coming Tuesday, we have a tumor board with MD Anderson and all of the other partners around the country, the Scripps Clinic and in Florida and Arizona. And so we'll present 5 or 6 different cases and get the input from all of the other national experts. These tumor boards are also held weekly at Overlook and at Morristown. So if we don't present a case there, we'll present them at some of the other hospitals. So I don't know what percentage of patients actually get presented at tumor boards, but it's probably upward of 60% of patients in one tumor board or another.
Is this something that came with the MD Anderson connection, or is this something done?
No, this is something that's gone on for 20, 30 years.
It's a great idea.
And then, like he said, sometimes we only have time for 3 cases. And so we never make a patient wait 2 weeks,
Yeah.
right? And it's really because of all of our schedules, operating room, et cetera. So then, just to give you an example, we had a tumor board probably about 3 weeks ago that we couldn't get through all the cases. So I just texted the surgeon and said, I saw blah, 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 and he called me. And, Winnie calls, Billy calls, the other breast surgeon called. So we don't make the patient wait, but sometimes it's really reassuring to get that kind of almost silent second opinion without having to go to the doctor.
Great.
We love it. It's how we get to know each other and trust each other and respect each other. And it keeps us thinking, it keeps us on our toes. We do discuss, if I can just briefly with the tumor board, because it does link into what you presented. In addition to the stage and what treatment we recommend, we talk about whether there are clinical trials, whether the patient is in psychosocial distress, and actually both Serge, you're not sure clinical oncology, I think you do, but we have it in the first thing that a patient fills out when they come into our office is a psychosocial distress scale. We don't call it that, it's a thermometer, tell us what's bothering you, and we use that as an indicator. Truly on a scale of 0 to 10, if someone's saying a 2, they really mean an 8. And so although Dr. Nickel was saying that, giving the example of a patient crying in chemo, we often catch it earlier. And I think I've called your department probably 5 times this week with a score of 2. Because that makes us as physicians say, hey, something's going on, and then when you dig deeper, and I think it's very helpful. So we do discuss like psychosocial, do they need a genetics test? And so it's a way to keep us honest, so to speak, and keep us on our toes.
Okay, great. It's a great idea.
Anyone else?
hope you enjoyed it. It's a great exercise for us and reassuring for patients. Hopefully this gave you a little glimpse of how we do it. I wanted to thank Christine for being here with us. She started her day at what, 3:30 this morning?
Yeah.
So we appreciate the time and the effort. That was very nice of you. Thank you so much.
Yeah, I like this guy better than this one. But truly, this information means so much to me personally, to all of us here, and I will do whatever I can to spread the word of the great work that you're doing and all the support that you're giving to people, and it's just been an honor for me to be here, so thank you. Thank you to our panel.